Of late intrauterine fetal death and stillbirth, Green Top Guideline number 55 is the topic of our discussion today. When we talk about the risk factor for late IUFD, the non-modifiable risk factor include first of all the nulliparity. Another non-modifiable risk factor is maternal age above 35. Also, maternal age below 20 years is another non-modifiable risk factor. Black, Asian, and other non-white women are also included among the non-modifiable risk factors for late IUFD. Moreover, previous stillbirth, previous adverse pregnancy outcomes are also non-modifiable risk factors, which include the preterm birth, preeclampsia, fetal growth restriction. Also, we will include the multiple pregnancy, advanced gestational age of more than 41 weeks, fetal growth restriction, and or SGA of less than 10 centile. The potentially modifiable risk factors include the pre-existing conditions, hypertension, obesity, overweight or weight gain, smoking of more than 10 cigarettes per day, alcohol use, illicit drug use, going to sleep supine, living in areas of most deprivation. Now, what is the optimal method for diagnosing late IUFD? First of all, ultrasonography is essential for accurate diagnosis of late IUFD and should be available at all times. A second opinion should be obtained for the diagnosis. Auscultation and cardiotocography should not be used to diagnose late IUFD. Women should be prepared for the possibility of passive fetal movements. If a woman reports fetal movements after the scan to diagnose late IUFD, a repeat scan should be offered. What is the best practice for communicating the diagnosis and subsequent care? If a woman is unaccompanied, ask her to make call to partner, family, or friends. An appropriate place for discussion should be found. Clear languages with the no jargons should be used. The woman and her family should be given time to absorb any news. Discussions should aim to support maternal and parental choice. The woman and her family should be given written information to supplement discussion. Care following diagnosis. The woman and her family should be given as much privacy and time alone as they wish. Details of the birth plan should be discussed, including the mode of the birth, pain relief, timing, and memory making opportunities. All the staff should be made aware of the baby's death. Staff should be sensitive to sounds that may be upsetting for bereaved parents. Continuity of caregiver should be ensured where possible. What are the recommendations for timing and mode of the birth? The mode of the birth should be an informed decision between the parents and an appropriately experienced clinician. A detailed, informed discussion should be undertaken with the parents of both physical and psychological aspects of vaginal versus cesarean birth. Late IUFD is not contraindication to pool birth. Recommendations about the labor and birth should consider the woman's choices. Women who are severely unwell or at high risk of deterioration should be strongly advised to take immediate step toward the birth. If a woman return home before labor, they should be given a 24-hour contact number for information and support. Women contemplating prolonged expectant management should be advised that diagnostic value of post-mortem may be reduced and the appearance of the baby may deteriorate. How should labor be induced for a woman with an unscarred uterus? A combination of mifepristone and prostaglandin preparation should usually be recommended as the first-line intervention for induction of the labor. Misoprostol can be used in preference to prostaglandin E2 because of equivalent safety and the efficacy with a lower cost but at doses lower than those currently marketed in UK. Women should be advised that vaginal misoprostol is as effective as oral therapy but associated with fewer side effects. A single 200 mg dose of misoprostol is appropriate for this indication, followed by 400 microgram every 3 hours if the woman is at 24 to 24 plus 6 weeks of gestation. At 25 to 27 plus 6 weeks of gestation, 200 microgram every 4 hours, and from 28 weeks of gestation, 25 to 50 microgram vaginal misoprostol every 4 hours, or 50 to 100 microgram oral misoprostol every 2 hours. The investigations for late IUFD include maternal standard hematology and biochemistry, including CRP and bile tests. Secondly, the platelets count to test for the occult DIC. Other tests include maternal coagulation time and plasma fibrinogen, and the reason for test is DIC. In fact, the maternal sepsis, placental abruption, and preeclampsia increase the possibility of DIC. That's why this testing is done. It is especially important for regional anesthesia use or if there has been an interval of more than 48 hours since IUFD until birth. At what time should these tests be done? As soon as possible after diagnosis of sepsis, abruption, preeclampsia, or other predisposing condition before regional anesthesia. The Klehr tests are done for the diagnosis of lethal feto-maternal hemorrhage. These tests decide the level of requirement for anti-D gamma globulin. In fact, the feto-maternal hemorrhage is the cause of late IUFD. Klehr test should be recommended for all, not simply those who are Rh negative. The test should be undertaken before birth, as red cells might clear quickly from maternal circulation. In Rh negative women, a second Klehr test also determines whether sufficient Rhd has been given. These tests are done as soon as possible after the diagnosis of fetal death or latest within 3 hours from the birth. Other tests include maternal bacteriology. The reason for tests include diagnosis of the infection. So for that, we do the blood culture, midstream urine, vaginal swab, and the cervical swabs. In fact, when there is suspected infection, including Listeria monocytogenes and chlamydia species, then these tests are essential. These tests are indicated in the presence of maternal flu-like symptoms, abnormal liquor, prolonged rupture of membranes. The reason for doing maternal serology is viral screen or tropical infection. The additional comments include undiagnosed maternal fetal infection, and timings include booking visit and if patient presents with history of travel to endemic areas. The reason for doing maternal random blood sugar include undiagnosed maternal diabetes. Additional comments: rarely a woman will have incidental undiagnosed pre-existing diabetes mellitus. And the timings as soon as possible after diagnosis. Reason for doing maternal HbA1c include undiagnosed maternal pre-existing diabetes or GDM. Additional comments include it is done to exclude occult type 1 or type 2 diabetes can be indicative of GDM if HbA1c is more than 41, and the timing before discharge. Maternal thyroid function tests. The reason for doing test is to diagnose the maternal thyroid diseases. Additional comments include TSH and free T4, T3 level, and the timings before discharge. Maternal thrombophilia screening. Reason for test include maternal thrombophilia. Additional comments include it is indicated to screen APS, especially if the evidence of fetal growth restriction or placental disease. Antiphospholipid screens to be repeated if abnormal. Advised to include antibodies against beta-2 glycoprotein 1, lupus anticoagulant, and anticardiolipin antibodies in antiphospholipid screen. Inherited thrombophilia screen is not routinely indicated. The timings include screening at 6 weeks after birth, not reliable in pregnancy. Parenteral blood for karyotype. Reason for testing include parenteral balance translocation or parenteral mosaicism. Additional comments: it is indicated if a fetal unbalanced translocation is there, it is recommended by geneticist. Fetal genetic testing fail and history suggestive of aneuploidy, fetal anomaly on post-mortem, previous unexplained IUFD, recurrent miscarriages. The timings: it is done as soon as possible after diagnosis of fetal genetic anomaly or suspicion of genetic anomaly. Maternal toxicology is done in case of occult drug use. The reason for test: with the consent it is done if history and or presentation are suggestive. Additional comments include urine is efficient and effective, nails and hairs can be used. Timing as soon as possible after birth, after the diagnosis of the fetal death. Fetal and placental microbiology. Reason for test is fetal infection. Additional comments: it is more informative than maternal serology for detecting viral infection. Timing as soon as possible after the birth. The post-mortem examination include external examination, autopsy, microscopy, X-ray, placenta, and cord examination. Another important investigation is ultrasound scan, MRI. External examination should include weight and length measurements. Fetal growth restriction is a significant association for late IUFD. It is absolutely contraindicated if parents do not wish or because the written consent is essential, and as soon as possible after birth and after parents consent COVID-19 PCR test. Now, what is the best practice for induction of the labor of women with a history of lower segment cesarean section? A discussion of the potential benefits and harms of induction of the labor should be undertaken by an appropriately experienced obstetrician. Women undergoing vaginal birth after cesarean should be closely monitored for the features of scar rupture. Oxytocin augmentation can be used for the VBAC, but the decision should be made following discussion with a consultant or obstetrician with equivalent training. There is insufficient evidence available to recommend a specific regimen of misoprostol for the use at more than 27 plus 6 weeks of gestation in the women who have had previous cesarean birth or transmural uterine scar. Women with more than 2 lower segment cesarean births or atypical scars should be advised that the safety of induction of the labor is unknown. What are considered suitable facilities of birth? During labor, women should be cared for in an environment that provides appropriate facilities for obstetric emergency care according to their individual circumstances. Maternity units should aim to develop a special labor ward room for women who are physically well with an otherwise uncomplicated late IUFD that pays special heed to emotional and practical need without compromising safety. Care in the labor should be given by experienced midwife with an accessible experienced obstetrician. What are the recommendations for intrapartum antimicrobial therapy? Women with a sepsis should be treated with intravenous broad-spectrum antibiotic therapy, including anti-chlamydial agent. Routine antibiotic prophylaxis should not be used. Intrapartum antibiotic prophylaxis for the woman colonized with the group B streptococcus is not indicated. Are there any special recommendations for the pain relief in the labor? All usual modalities of intrapartum pain relief should be made available to the woman with late IUFD unless there are specific contraindications. What care should women receive before returning home? Women should be cared for in an environment that provides adequate safety. Lactation, milk donation, and milk suppression should be discussed with the woman. Women should be advised which ongoing physical symptoms can be expected. Women should have continuity of the care specialist or bereavement midwife. A discussion on contraception should take place. What are the options for suppression of lactation? Women should be advised that almost 1/3 of those who choose non-pharmacological measures to suppress lactation experience excessive discomfort. Women should be advised that dopamine agonists successfully suppress lactation. Careful consideration and balance of the risk and benefit should be undertaken when using dopamine agonist in the woman with hypertension or preeclampsia. What are the criteria for thromboprophylaxis? Women should be routinely assessed for thromboprophylaxis, noting that late IUFD and current pregnancy is an independent risk factor for VTE. Heparin thromboprophylaxis should be discussed with a hematologist if the woman has DIC. Who should be informed of late IUFD? All the key staff responsible for the care of the woman during pregnancy and afterward should be informed of the events. All existing antenatal appointments should be cancelled. Maternity unit should keep a list of likely specialists that needs to be contacted. Primary care healthcare provider should be informed where the woman will be staying when they leave the hospital. What are the general principles of investigation? First of all, detailed history taken is vital first step. Secondly, clinical and laboratory tests should be recommended to assess maternal well-being. Parents should be advised that with full investigation, a possible or probable cause can be found in up to 3/4 of late IUFD. Parents should be advised that when a cause is found, it can potentially influence care in future pregnancy. Healthcare professionals should be aware that an abnormal test result is not necessarily related to late IUFD. Correlation between the test and post-mortem examination should be sought. System that take into account the fetal birth weight centile and capture multiple contributing factors should be used to categorize late IUFDs. What tests should be recommended to identify the cause of late IUFDs? All the women with the late IUFDs should be offered a post-mortem genetic testing and placental pathology. What special actions should be recommended for women with a rhesus D negative blood group? These women should be offered Klehar test. If there has been large fetal-maternal hemorrhage, the dose of anti-D should be adjusted and Klehar test should be repeated 48 hours to ensure fetal red cells have cleared. Anti-RHD immunoglobulin should be given within 72 hours of fetal-maternal hemorrhage. And fetal blood group should be determined by cell-free DNA testing of maternal blood when required. What special actions should be recommended for women with the rhesus D negative blood group? What precautions should be taken when determining the fetal sex? Parents should be advised before the birth about potential difficulty in sexing the birth. To experienced healthcare professional, midwives, obstetrician, and neonatologist should examine the external genitalia of the babies. What is the best practice? Guidance for cytogenetic analysis of the baby. All women should be offered cytogenetic testing and written informed consent must be taken. What information should be discussed with the women and their families regarding the perinatal post-mortem? Parents should be offered full post-mortem examination to help explain the cause of late IUFD. Ample time should be allowed for the discussion and ensure that discussion take place in quiet private place. What physical, psychological, and social problems can follow late IUFD, and what is the best practice for their use of intervention that might aid psychological recovery? Healthcare professionals should be aware of and responsible to possible variations in individual and cultural approach to death. Appropriate counseling should be offered to all women and their partners. What is the evidence for seeing, holding, naming, and mementos? The opportunity to spend time with the baby and make memories with the baby should be actively supported and offered. It is reasonable to offer parents a chance to see their baby more than once, and they should be informed that they can change their mind at any point, but once the decision has been made, it should be respected. Maternity units should have facilities for producing good quality photographs, palms and footprints, and locks of hairs with the presentation frames. What are the legal requirements for medical certification of stillbirth? Parents should be provided with a medical certificate certifying the late IUFD. Parents should have a discussion and be provided with a written information about a registration process, including where and how to register. Inform parents that baby must be registered within 42 days. What are the recommendations for spiritual guidance, burial, cremation, and remembrance? Maternity units should have arrangement with all common faiths and non-religious spirituals organization as a source of guidance and support for parents. The legal responsibility for child's body rests with the parents but can be delegated to hospital services. What advice should be given about fertility? With regard to inter-pregnancy interval, it is important to balance physical and psychological considerations. How should healthcare professionals caring for women who experience a stillbirth be supported? Healthcare professionals should be offered training and support when caring for the parents who experience a late IUFD. What are the options for perinatal mortality reviews, process, and follow-up meeting? The wishes of women and those who wish to be involved should be discussed when arranging the follow-up. The parents should be given opportunity to engage in the review process, and family should be fully informed of the likely time scale to review and follow up. What are the recommendations for content of follow-up appointments? Parents should be advised about the cause of late IUFD, chance of recurrence, and any specific mean of preventing further loss. What are the risk management standards for IUFD? Maternity units should ensure they are tracking their outcomes and benchmarking against other organizations using the National Indicators Dashboard. What are the standards for documentation? Standardized checklist can be used to ensure that all appropriate care options are offered and response to each is recorded. Consent for perinatal post-mortem examination should be documented using nationally recommended form. All the stillbirths should be reviewed in multi-professional meeting using standardized PMRT to ensure lessons are learned from each IUFD and shared widely. So that was all about the summary of stillbirth and IUFD RCOG guideline. Subscribe on Obs and Gynae and follow the Facebook page of on Obs and Gynae. Allah Hafiz.